Okay, morning everyone, or good afternoon, wherever you are. I am Isabella. I'm one of the fifth years on the MUPPITS committee, and I am going to be talking today about the R3 paediatric surgical conditions. Um, Sort of an overview of the four listed here. I will be going into just a little bit of detail about them, only for the point of view, from the point of view of the fact that some of these conditions are associated with certain syndromes. And so, whilst the question may not be specifically asking about these conditions listed here, it might be worthwhile to still know the associations they have with those syndromes, because it could then give you a clue as to what is actually going on. So, the four of them are intestinal atresias, tracheoesophageal fistulas, abdominal wall defects, and diaphragmatic hernia. For the purpose of today, the intestinal atresias I'll be covering are the duodenal and biliary, but be aware that there are others. And I found in my experience, the two that come up on exams the most is duodenal and biliary. So let's begin with that. We have on the left an abdominal x-ray of a neonate, and on the right, we have an ultrasound of the biliary tree of a neonate. On the left, that is showing the classic double bubble sign associated with duodenal atresia. And if you can appreciate my cursor, you can see here that we have the stomach, and you can see here that we have the duodenum, and then we have the absence of distal gas. So that in itself, here is our double bubble, but the absence of distal gas as well, too, is pretty pathognomonic for duodenal atresia. Obstruction of an atresia of the segment is due to failure of recanalization of the second part of the duodenum during fetal development. Then on the right, we have our ultrasound of the biliary tree. And if you can appreciate this arrow, you wouldn't be expected to know this at an exam level, but I think it's just interesting to understand the pathology of it. That is a fibrous tissue, and it's anterior to the portal vein, and they call it the triangular cord sign, and it represents the ductal remnant of the extrahepatic bile duct, so effectively showing that the biliary tree is non-functional. The two stems down the bottom are things that have come up on exams of presentations. You can cover them in your own time, but bear in mind too, they can be chopped and changed year to year, so they're not viable. So duodenal and biliary is what we're going to be talking about. So we'll start with duodenal in terms of presentation. Antenatally, one of the clues is polyhydramnios. Due to the impaired swallowing of the amniotic fluid, it just cannot progress through their bowel. Postnatally, what you'll see usually in the first 24 to 38 hours of life is either a failure to pass meconium and or bilious vomiting, which, as you will all know, is always abnormal in a newborn. When you examine them, you can sometimes see upper abdominal distension and sometimes visible gastric peristalsis. Interestingly and importantly, about 30% of infants with duodenal atresia have Down syndrome. So an important association to remember. Moving to biliary atresia, the hallmark feature is persistent jaundice beyond 2 weeks of life. So you remember the first 24 hours, pathological, first 2 weeks, physiological, beyond that, usually also pathological. So these babies have pale clay-colored stools and dark urine due to conjugated hyperbilirubinemia. On examination, you'll often find hepatomegaly, sometimes splenomegaly, and failure to thrive, also abdominal jaundice. 90% of infants with biliary atresia don't have a syndromic association, though, so it's a bit different. The other thing that you can see in both is signs of dehydration, because they're not actually taking anything in from their bowel. As we spoke about before, in terms of investigations and imaging, for duodenal atresia, the abdominal x-ray is the key investigation, classic double bubble sign, very buzzwordy. Contrast studies can be used if the diagnosis is unclear, and echo is really important because of the association with congenital heart disease. And so these babies can get a big screen, including karyotyping and all that, because of the company this keeps. They may also get metabolic alkalosis from the vomiting, and then derangements in their electrolytes from the dehydration and vomiting too. For biliary atresia, initial investigations, you can do your LFTs, which, as we spoke about before, with the bilirubin abnormalities. ultrasound as well too is performed, and you'll see an absent or small gallbladder. They use a Kasai classification for determining what type of biliary atresia it is. There's type 1, type 2A, type 2B, and type 3. In some cases, they need a liver biopsy or a procedure to determine exactly what's going on. And there's also the nuclear medicine scan, which is the HIDA scan, which can be done too. So for duodenal atresia, preventive management, keeping the little person nil by mouth, nasogastric decompression, IV fluids, and correcting of electrolytes if it needs to be. The surgeries are as listed there. And the key is post-operatively, they usually need TPN until their bowel function returns, just to get them nutritionally up to speed. For biliary atresia, again, you can see that there's a big focus on nutrition because they're not doing much in the way of absorbing. And so you really want to try and keep them, as I said, up to speed with that. But the definitive treatment is a Kasai porto enterostomy. And the best outcomes for this in the literature say that it should be done within the first 8 weeks. Unfortunately, some children may fail that. And so they may end up needing a liver transplant, sadly. So next we have tracheoesophageal fistula and esophageal atresia, plus or minus. So you can have esophageal atresia without fistula, and you can have a fistula without atresia. These are the 5 types here. I apologize for the American spelling. I don't have the exact proportions listed here, but I'm about to tell you which one's the most common. I think it's just a good way to visualize the anatomy of what's going on and help you understand some of the problems you can run into if that is the way things are set up in that baby. So dramatic condition, usually antenatal history can involve polyhydramnios because the fetus can't swallow the amniotic fluid normally. There's a recurrent theme here. The classic presentation is the 3Cs, so choking, coughing, and cyanosis with feeds. They can have excessive salivation and frothing at the mouth because they can't swallow their own saliva, okay? Type C is the most common, and that accounts for about 85% of cases, and that's a proximal esophageal atresia with a distal tracheoesophageal fistula, okay? On examination, the pathognomonic sign is an NG tube being able to pass approximately 10 to 12 centimeters from the gums. It'll just coil up in the upper esophageal pouch because the segment isn't, you're not able to pass anything through. You can see abdominal distension too from air entering the stomach through the fistula. So the other thing to remember too is that this keeps company, so the VACTERL associations. So as listed there, vertebral, anal, cardiac, renal, and limb anomalies. So these kids also too get lots of screening done to them and have a big examination of what's going on. Chest X-ray is diagnostic though, so the nasogastric tube coiled up in the upper esophageal pouch, and crucially too, there can sometimes be a gastric air bubble present in the presence of a distal fistula. You could also too, depending on the presentation, see signs of aspiration pneumonia. Echo essential, just because we spoke before about the VACTERL associations, 20% of these babies have cardiac anomalies, so they need to be screened. Pre-op is baby should be positioned head up at 30 degrees, continuous suction, IV fluids, plus or minus antibiotics if they are looking like they're sick or have signs of aspiration pneumonia. And you want to avoid bag glass ventilation because this can cause gastric distension through the fistula and cause a new problem in and of itself. Surgical repair, I'm not going to go into the specific details of because I'm not qualified to talk about that, but you can imagine there's quite an involved approach. Post-operatively, these babies can need prolonged ventilation, and complications can include anastomotic leak. It's difficult to get a consensus in the literature, but I've seen figures ranging from 8 to 20%. These kids also too can have persistent gastroesophageal reflux and then need to be followed up later in childhood for the ramifications of that. So next up, we have abdominal wall defects, and we've got gastroschisis and exomphalus. So exomphalus is on the left here, baby A, and gastroschisis is on the right. And I know that because gastroschisis has no peritoneal covering and exomphalus has a peritoneal cover. So if you were going to remember anything, it would be that. we'll move on to the actual slide. Gastroschisis is usually an isolated problem. So it's actually rarely associated with chromosomal abnormalities or other major non-gastrointestinal congenital abnormalities. But between 10 to 15% have associated intestinal atresia, which is interesting. But in contrast, associated anomalies are observed in up to 72% of infants with exomphalos. So gastroschisis has it present. It's bowel eviscerating, usually to the right of the umbilicus, but most importantly, there's no covering membrane. And the bowel can be described as thickened or matted from prolonged exposure to the amniotic fluid. Okay, exomphalos is herniation through the umbilicus, but crucially, it's covered by that membrane of amnion and peritoneum, and the umbilical cord inserts directly into the sac. Often part of a syndrome like Beckwith-Wiedemann or associated with chromosomal abnormalities, as I said. Both conditions, though, can cause immediate fluid losses and hypothermia risk because of the high surface area to volume ratio of a neonate, and you've got exposed organs. So more than 90% in Victoria of cases of gastroschisis are antenatally diagnosed, and almost 100% of cases of exomphalos are diagnosed antenatally via ultrasound. So most of the time, these babies are known about before they're delivered. They're usually obviously very obvious at birth, but investigations tend to focus on the associated anomalies. So a chest X-ray can exclude a diaphragmatic hernia. And again, recurrent theme, echo is quite important, especially for exomphalos, which has a high rate of cardiac anomalies. Many of these defects are diagnosed antenatally, the accompanying defects too. So immediate management, pretty similar for both in the short term. So you need to cover the defect with cling wrap, make sure the little baby's kept nice and warm because temperature control is really important. Establishing vascular access for fluid resuscitation and a nasogastric tube to prevent bowel distension. Surgical approach depends on size and intactness of the sac. For gastroschisis, if it's small, they might be able to go with a primary repair. Larger defects usually require a staged approach, and they can unfortunately get a bit of an ileus, quite a prolonged ileus, and require TPM for quite some time. For exomphalos, small defects might be suitable for primary closure too. Large defects, they can be harmful because they have due to high intra-abdominal pressure. So the sac, they can allow it to granulate and epithelialize over weeks or months, and then there's an eventual elective closure once the baby's stable. Long-term issues, growth monitoring, and the potential for future hernias at the site of repair. Last but not least, we have congenital diaphragmatic hernia, which is a pretty scary presentation. On the right, we have a diagram outlining the pathophysiology, and on the left, we have the classic chest X-ray of a neonate with CDH. You can see the bowel contents totally occupying that left lung, and you can also see some mediastinal shift as well. This is both a medical emergency and a surgical emergency. These are sick little babies. Fantastically, in Victoria, with the virtual universal occurrence of mid-trimester ultrasounds for fetal abnormality, more than 80% of these cases are now prenatally detected, which is fantastic because these deliveries need to be planned well in advance. They involve a highly specialized and many specialty multidisciplinary team, and it's usually a very well choreographed approach. I remember when I was doing my pediatric rotation last year, I was shown a video of a neonate just delivered who was being intubated straight away, and they had a diaphragmatic hernia, and it was quite an intimidating video, but amazing to see how everyone works together so seamlessly. So very sadly, the survival rate for all cases diagnosed is approximately 50 to 60%. But if a coexistent significant abnormality is present, survival is less than 10%. So very high mortality rate. Just illustrating the importance of the fact that these babies need to be discovered before they are born. Presentation can be quite dramatic. So severe cyanosis and respiratory distress can happen from the moment they're born. One of the key physical findings can be a scaphoid abdomen. It looks hollow and empty because the abdominal contents are in the chest. The heart sounds can be displaced to the opposite side due to the mediastinal shift. Reduced air entry can be heard on the affected side, and you may actually hear bowel sounds in the chest. The pathophysiology, though, doesn't just involve herniation of the bowel contents into the chest, but it also involves pulmonary hyperplasia, because the affected lung is underdeveloped. And so you can, as a corollary to that, develop pulmonary hypertension, which you can imagine has a whole suite of nasty effects. Chest X-ray is usually diagnostic, and chest X-ray is diagnostic, and I would say what you would be likely to be presented with in an exam format, whether the findings alone or the X-ray and the findings. As previously mentioned, bowel loops in the chest, mediastinal shift, lung hyperplasia. Blood gases can show severe respiratory acidosis and hypoxemia from that lung hyperplasia. And then an echo is important, common theme, to assess cardiac function and to rule out structural heart disease. Many of these cases, as we mentioned, diagnosed antenatally, but the importance too is allowing for planned delivery at a centre that has capacity to escalate care, so things like ECMO available. It's a medical emergency that these babies require stabilization medically before they can go on to have operative or surgical management. So they immediately need resuscitation. So another case where bag mask ventilation is avoided, because this can worsen gastric distension and further compromise their breathing. Immediate intubation, mechanical ventilation are usually what's pursued, and nasogastric decompression as well. The key is gentle ventilation, because you want to avoid pneumothorax in the hyperplastic lung. And something I found in the literature is that units that report very high survival rates concentrate very, very intensely on minimizing lung injury, especially in the initial hours after birth. If conventional ventilation fails, as I mentioned, ECMO may be required. These kids get a whole bunch of things thrown at them: muscle relaxants and sedatives, ventilation, obviously, ventilatory systems, pulmonary hypertension treatment, inhaled nitric oxide if the little person has impaired gas exchange. They are really sick little people, and they need a lot of support. According to the literature, less than 10% of babies do end up needing ECMO, though. Surgery should only be performed once the baby is stabilized, as I mentioned. And again, I'm not going to go into the specifics of that, but it's quite an involved approach, as you can appreciate. But long-term issues are really the crux. So these children often have chronic lung disease. They can require long-term oxygen, gastroesophageal reflux, and there's a 5 to 15% chance of this hernia recurring. There's also an increased risk of neurodevelopmental problems in these kids, and so they need long-term multidisciplinary follow-up, a lot of counselling and a lot of things going on at once. So that's a SparkNotes overview of the R3 paediatric surgery conditions. As always, please reach out if you have any further questions, but all the best for your exams and apexes at the end of the year.